Welcome to the deep dive. Today we're tackling a really critical and pretty complex area in medicine, necrotizing soft tissue infections, or NSTIs.
That's right.
Our guide for this is Chapter 18 from Hyperbaric Medicine Practice. It's called Selected Aerobic and Anaerobic Soft Tissue Infections. Think of this as, well, your shortcut to understanding these pretty serious conditions.
Yeah, these infections, they're a growing concern, both in surgical and medical settings, really. And this chapter gives a really detailed overview.
Okay.
Our goal here is basically to pull out the most important information for you. We'll look at the history, what causes them, how they're diagnosed, the treatments, trying to keep it clear and focused.
Okay, let's unpack this then. Right from the start, the chapter makes it clear that NSTIs, these infections involving like a mix of different bacteria, they're becoming more frequent and maybe more importantly, more severe.
Exactly. And that's especially true for people whose immune systems are, well, compromised.
So we're talking about conditions like diabetes.
Diabetes, yeah. Cancers, problems with blood flow, alcoholism, people on immunosuppressive drugs, even drug addicts, neutropenic patients. The list is quite long.
And it's striking. The chapter points out just how many ways these can start. It's not just major trauma, is it?
No, not at all. It can be sharp trauma, blunt trauma, sure, but also around foreign bodies, like implants or splinters, or even spontaneously.
Spontaneously, like Fournier's gangrene.
Exactly like Fournier's gangrene, which affects the genital area. The chapter even mentions cases after things like volcanic eruptions.
Wow.
And in children, too. So it really highlights that these aren't confined to, one specific group or situation.
And it's not always an obvious injury either. The chapter notes they can pop up even after supposedly sterile operations like liposuction.
Yeah, suction lipectomy is mentioned. And also in conditions like Crohn's disease. It just underlines how sometimes these infections can arise in really unexpected ways.
Which brings us to, I guess, a really critical point the chapter makes. Recognizing them early is tough.
Very tough. And the chapter really stresses this. Identifying NSTIs early on can be difficult. Any delay in getting treatment, or if the first treatment isn't quite right.
The consequences are serious.
Very serious. The morbidity, the level of illness they cause is significant, and the mortality rates. They're high. We're talking 20% maybe, but up to 70 or even 80% in some groups.
80%, that's staggering.
It is, especially in older patients, people who are already debilitated, diabetics, particularly those with something called synergistic necrotizing cellulitis. It just shows that dangerous mix of, a weakened immune system and bacteria working together. That's a key challenge.
So to really get a grip on this, the chapter kind of walks us through the history, right? Starts way back.
It does. Jean-Alfred Fournier, 1883. He described this condition, gangrene foudroyante de la verge, basically, rapidly progressing gangrene of the penis.
Fournier's gangrene.
That's the one. And what was striking was that he saw it in 5 young men who were otherwise healthy, and even then the mortality was high.
But the chapter says similar things were described even earlier.
Oh, much earlier. It's quite sobering. Hippocrates, way back in the 5th century BC, described conditions affecting the genitals that sound very similar, with tissue breakdown. And then you see scattered accounts through the centuries. Borean in 1764, Habler in 1848, descriptions that seem like they could be early cases of what we now call necrotizing fasciitis.
So Fournier's observation was important, but it wasn't completely out of the blue.
Not entirely. The roots of trying to understand these devastating infections go way back. It just took time to piece it all together.
Then the timeline jumps forward a bit. U.S. Civil War.
Right. Joseph Jones, a surgeon back then, documented what he called hospital gangrene. Seems like it was a major problem in field hospitals.
And then the 20th century brings figures like Malini.
Yes, Frank Malini in 1924. He identified a specific type of bacteria, hemolytic streptococci, as a cause of a certain type of gangrene. It became known as Malini's ulcer.
Okay.
And around the same time, Cullen described something called postoperative progressive bacterial synergistic gangrene.
Synergistic, meaning the bacteria work together.
Exactly. That's the key idea Cullen highlighted. It wasn't just that multiple bacteria were present, a mixed infection. It was that specific combinations seemed to help each other, making the infection much worse.
How does that work? Like, how do they help each other?
Well, they might produce toxins that benefit the other bacteria. Or maybe one type creates an environment, like low oxygen, that allows another type to thrive where it normally couldn't. It's a crucial distinction, this active cooperation versus just coexisting.
And the chapter suggests this historical picture got a bit confused. Malini, Cullen, Fournier. Their findings maybe got mixed up.
Yeah, it seems there was some confusion, linking different findings inappropriately, pinpointing the exact microbial culprits, and understanding concepts like synergy has been a long, complex road.
And the main bacteria involved weren't always the same.
That's another interesting point. Malini initially saw mostly streptococci, but later studies didn't find them as frequently as the primary cause. Then Wilson, in the late 40s, early 50s, really focused on the deep fascia, the connective tissue layer.
Right, the layer under the skin.
Exactly. He recognized that necrosis, or death of that fascia, was key, so he renamed hemolytic streptococcal gangrene to necrotizing fasciitis, putting the focus squarely on that deeper tissue involvement.
The chapter also raises a really practical point about diagnosis, about when we actually see these infections.
Yes, that's critical. It points out we rarely catch these right at the very beginning, and any antibiotics the patient has already had or any surgery they've undergone.
That changes the picture.
Hugely. It can significantly alter the bacteria we find when we take cultures later on. And this, the chapter notes, is often overlooked in the medical literature when people report on the bacteriology.
So the cultures might not show the original bad guy, so to speak.
Exactly. Are we culturing the initial trigger, or are we seeing bacteria that moved in later opportunists taking advantage of the situation? Plus, where you take the sample matters. The center of the wound versus the spreading edge might give different results.
They even mention a case where only Candida, a fungus, was found.
Yes, in a case of Fournier's gangrene. It just highlights the complexity.
And then there was the whole flesh-eating bacteria scare in the 90s.
Yes. The chapter gives context for that. There was a 1994 outbreak of invasive Group A Strep infections in England, and the media really sensationalized it.
But these infections weren't actually new then.
Not at all. The chapter makes it clear that severe infections like this weren't a new phenomenon. The key takeaway is, yes, streptococci can cause NSTIs, but often it's a mix of bacteria, polymicrobial, and the historical data. It's often been confusing and misinterpreted. That complexity is still relevant today. These polymicrobial infections are challenging.
Which probably makes classifying them difficult, too.
Extremely difficult. The chapter explains that coming up with one clear, consistent system is hard because the lines are often blurred clinically. And historically, this same condition got called many different things.
So how have people tried to classify them? What are the approaches?
Well, the chapter lists a few common ways. Sometimes it's based on the assumed main bacteria causing it, or the type of tissue that seems most affected, skin, fascia, muscle, or the kind of therapy that's typically needed, or how fast it's spreading, or even just the initial signs and symptoms.
But each of those has problems.
Right. They all have limitations because they focus on just one piece of a complex puzzle. If you have multiple bacteria, which one is the main one? Hard to say sometimes, and later on it can be tough to tell which tissue was hit first.
So is there a more practical classification?
The chapter mentions the Amsterdam classifications, based on work by Lettingham and Tarani, and focuses on the depth. It basically divides them into superficial infections.
Like progressive bacterial gangrene.
Exactly, affecting the skin and the tissues just beneath. Versus deeper infections involving the fascia, like necrotizing fasciitis, or even muscle, which is myositis or myonacrosis.
Okay, let's shift to etiology. What actually causes these?
Often it's a combination. You get anaerobic microorganisms, those bugs that thrive without oxygen, working together with aerobic gram-negative organisms.
And how does that anaerobic environment get started?
Well, local tissue hypoxia, just a lack of oxygen in the tissues is key. This can happen from traumatic crush injuries or just in patients with underlying health issues that affect blood flow.
Right.
This creates an environment with low or oxidation reduction potential, basically less oxygen available. And that's perfect for these anaerobic bacteria. Most NSTIs actually have this endogenous anaerobic component.
In this low oxygen environment, it does more than just help the anaerobes grow, right?
It does. This is really interesting. That hypoxic state also messes with our own immune cells, specifically the polymorphonuclear leukocytes.
The infection fighters.
Exactly. They don't work as well in low oxygen. So this allows other bacteria, the facultative aerobes, the ones that can live with or without oxygen, to multiply. And they use up even more oxygen, lowering the air further, and the whole process just accelerates.
Wow, so it's a vicious cycle. Injury or poor health creates low oxygen. Anaerobes thrive. Our defenses are weakened. Other bacteria jump in, making it even less oxygenated.
Precisely. It's a powerful and, frankly, scary mechanism.
And the signs you see reflect this.
They often do. You see tissue death necrosis, often a putrid, foul-smelling discharge. Gas reduction within the tissues is common, and the infection tends to burrow along those fascial planes we talked about.
But not the usual signs of infection. Redness, swelling.
Interestingly, those classic signs, rubor, calor, dolor, tumor, redness, heat, pain, swelling, are often less obvious, sometimes even absent in NSTIs.
And the gas. What kind of gas is it?
Things like hydrogen, methane, nitrogen, hydrogen sulfide. Seeing the gas is a big clue that bacteria are multiplying rapidly in that low oxygen, low A environment.
So the cause isn't just one thing.
Definitely not. The chapter emphasizes it's multifactorial. Local tissue factors, the patient's overall health, the specific mix of aerobic and anaerobic bugs, sometimes even fungi are involved.
And the entry point, how do the bacteria get in?
Local tissue trauma is common, surgery, even draining an abscess, traumatic injuries, but also seemingly minor things like injections, IV lines. They can all provide an entry point.
And the bacteria involved can change over time.
Yes. While strep might play an early role in necrotizing fasciitis, the bacterial picture can shift quickly. Other organisms colonize the area, and antibiotics obviously have an effect. The chapter also notes that invasive Group A Strep has become a bigger concern again recently.
What about that bacterial synergy idea again? Progressive bacterial gangrene.
It seems important there, yes. But the chapter also notes that no single specific combination of bacteria has been consistently nailed down as the cause.
Other contributing factors.
Local ischemia, poor blood flow is a big one. Think diabetes, arteriosclerosis. Also, the fascia itself isn't very vascular, doesn't have a great blood supply. And clots forming in the small subcutaneous vessels can cause secondary skin gangrene.
And underlying health.
Crucial. A weakened immune system is key. Diabetes mellitus comes up again and again as a major underlying condition. But interestingly, they haven't found specific immune defects that make someone uniquely susceptible just to NSTIs.
Okay, so diagnosing these, it sounds tricky. The chapter says it's mainly based on just looking at it.
Primarily, yes. Especially early on. The macroscopic appearance, what the affected area looks like to the naked eye, is often the most important initial clue. The patient's general condition or even early bacteriology results might be less decisive right at the beginning.
And those classic infection signs might be missing.
Right, but there are general signs to watch for. A high fever, maybe a really high white blood cell count, and signs that the infection is affecting the whole body, a severe systemic reaction.
Is there anything more specific? Lab tests.
The chapter mentions a model by Wall and colleagues. It uses white blood cell count over 15.4 times 109 per liter, or sodium below 135 millimole, to help flag an STI. But it's important context. That was mostly tested in IV drug users.
So maybe not universally applicable.
We need to be cautious applying it broadly, yeah. Really, what's crucial is just having a high index of suspicion and doing a very careful clinical exam.
And locally, what are the red flags on the skin itself?
Things like Belioz's blisters or fluid-filled sacs, severe pain, often seeming much worse than the visible signs would suggest, rapid spread of redness or discoloration, and crepitus, that crackling feeling under the skin from gas formation.
Gas. Nichols' algorithm is mentioned for that.
Yes, an algorithm to help evaluate gas-producing infections. But the bottom line is, once you suspect NSTI, you need to act fast. Immediate antibiotics and usually surgery are required. Maybe adjunctive hyperbaric oxygen in some cases, but the core is antibiotics and surgery.
What about identifying the bacteria quickly? Gram stain.
A gram stain can give some initial clues, looking at bacteria under the microscope. But the chapter stresses that tissue biopsies are much more valuable.
Taken from where?
From the spreading edge of the infection, or from deeper tissues obtained during surgical debridement when they remove the dead tissue. There's also mention of a rapid strep diagnostic kit, which could be useful sometimes.
And imaging, CT, ultrasound.
They can help define the extent, anatomically. How far is it spread? But the chapter strongly warns against delaying necessary surgery just to get imaging done.
So surgery shouldn't wait for a scan?
Absolutely not. Time is critical. And MRI findings they add can sometimes be nonspecific anyway.
So how do you confirm the diagnosis definitively?
Often the best way is direct inspection. Maybe making a small incision down to the deep fascia under local anesthetic. If that fascia looks gray, dead, unhealthy, that's a strong sign.
And then you proceed to surgery.
Then you'd typically go to exploration and debridement under general anesthesia. In some cases, like rapidly spreading closed infections with hemolytic bacteria, maybe a needle aspiration for a gram stain could give reliable early clues.
Okay, let's get into the specific types. Progressive bacterial gangrene, you said this one is more superficial.
Right. It affects the epidermis, dermis, subcutaneous tissue fat, lymphatics, hair follicles, But the key is it never involves the deep fascia. That's the defining difference.
And it includes things like anaerobic crepitant cellulitis.
Yes, that's listed under this category, along with pyoderma gangrenosum, some forms of erysipelas. It's often linked to a starting skin infection. It spreads outwards, centrifugally, with the tissue death usually following a purplish skin discoloration.
And you see a distinct border?
Typically, yes. Because the deep fascia isn't involved, you get this raised red border zone, maybe 1 to 2 centimeters wide. The speed of spread varies hugely, hours, sometimes months. You might see granulation tissue, healing, in the center with the necrosis at the edges, and it's usually painful.
What about the bacteria here?
Can be anaerobic, aerobic, or mixed. That idea of bacterial synergy seems relevant, but again, no single specific combo is the definitive cause. Best way to culture is tissue biopsies from that spreading edge.
And common culprits.
Often Group A Strep and Staph aureus, alone or working together. Strep is found quite often in cultures, followed by other aerobes and anaerobes, bacteroids, Clostridium, Enterobacteriaceae, Proteus, Pseudomonas.
Bacteroides fragilis is mentioned.
Yeah, usually as part of a mixed flora. It's thought to maybe indirectly affect the host's immune response, often seen alongside E. coli.
And that anaerobic crepitant cellulitis you mentioned, it produces gas but isn't gas gangrene.
Correct. It can be mistaken for it, but it's generally more benign. You see marked tissue necrosis, lots of soft tissue gas, but initially no deep fascia or muscle involvement. However, it can progress to clostridial myositis involving muscle if there's extensive damage or really poor blood supply.
And like other NSTIs, it's linked to underlying illness.
Very strongly, especially diabetes mellitus. That's the most common association.
Okay, now the big one. Necrotizing fasciitis. This is the deeper one.
Yes. This is a progressive, usually rapidly spreading inflammation primarily in the deep fascia. The subcutaneous tissue and skin necrosis happens secondarily. How fast the skin goes depends on how thick the subcutaneous fat layer is.
And it spreads quickly along that fascial plane.
Exactly. This category covers historical terms like hospital gangrene, suppurative fasciitis, Malini's ulcer, and Fournier's gangrene.
Where does it usually start?
Could be a surgical wound, a minor injury, insect bite, scrape, bruise, or like progressive bacterial gangrene. It can even seem spontaneous, including in kids. Often sudden, severe pain and swelling. The area might even feel numb. The redness spreads fast, but the edges are usually indistinct, blurry, unlike the sharp border in erysipelas.
And the key diagnostic feature?
The pathognomonic feature, the chapter calls it, is that fascial and subcutaneous necrosis, an extensive undermining where the skin and subcutis are separated from the deeper layers. You can sometimes feel this with a probe, or even your fingers sliding underneath.
And if you make an incision?
You'll often see yellowish-green, necrotic, dead-looking fascia. But the muscle underneath might still look healthy, at least initially.
What happens if it's not treated?
The skin gets dusky. Purplish patches appear with irregular margins. These can merge into big gangrenous plaques. The redness keeps spreading. The patient gets really sick, septic, high fever.
And the damage underneath is worse than it looks on top.
Much worse, usually. The fascial necrosis spreads far beyond the visible skin changes. Apparently, normal skin might be loose because the fascia beneath it is dead. The skin dies later because the small blood vessels thrombose, clot off. And the numbness happens because nerve fibers die too.
Where does it usually occur on the body?
One series found it pretty evenly split between the trunk and the extremities.
And Fournier's gangrene is specifically necrotizing fasciitis of the scrotum.
Initially, yes. Starts in the scrotal fascia, leading to skin necrosis, that black spot description. But it can spread up the abdomen, down the legs. Because the scrotal subcutaneous layer is thin, the skin necrosis shows up early.
Harder to spot in women.
Potentially, yeah, because the subcutaneous layer is thicker. The chapter highlights a high incidence in diabetic women, often with high mortality.
And what about synergistic necrotizing cellulitis? Is that different?
The chapter suggests it's probably a severe form of necrotizing fasciitis, or maybe non-clostridial myonecrosis muscle infection, not from Clostridium. It involves widespread deep tissue damage fascia, subcutis, muscle, and severe systemic toxicity.
Where does that tend to occur?
Frequently in the perianal region, often after poorly treated abscesses. Again, a strong link to diabetes in older patients. Risk factors for death include diabetes, age, malnutrition, hypertension, IV drug use.
And the bacteria causing it. Still confusing.
Yeah, some confusion remains.
Yeah.
Malini found strep initially, but later staph became common too. Usually it's a mix of aerobic and anaerobic bacteria, Peptostreptococcus, Bacteroides, Fusobacterium, Strep pyogenes, Staph aureus, Klebsiella, Pseudomonas, Enterobacteriaceae, fungi, even Clostridia sometimes.
Hard to tell who's driving it.
Very hard. Distinguishing the positive bugs from just bystanders is tough. Early Fournier's cases apparently had pure strep cultures, but the pattern changes based on antibiotics, debridements, patient factors.
But strep is often involved at the start.
Believed to be, yes, a crucial role early on. And something else to be aware of. Streptococcal toxic shock syndrome, or strep TSS.
That's really serious, Frank.
Extremely serious. It can accompany necrotizing fasciitis and carries a very high mortality rate. The bacteriology of synergistic necrotizing cellulitis, though, seems pretty similar to other forms of necrotizing fasciitis.
Okay, last category. Non-clostridial myonecrosis. So muscle infection, but not gas gangrene.
Right. Gas gangrene, caused by Clostridium, is the most frequent and devastating anaerobic muscle infection. But there are other forms. That synergistic necrotizing cellulitis we just discussed, some might classify it here, or as NF with muscle involvement later.
And other causes.
Anaerobic streptococci can cause it, mainly seen in IV drug users. Distinguishing it from true gas gangrene can be tough.
How does it look different?
Streptococcal myositis might look more inflamed initially. The muscle necrosis might be later, maybe greenish. Gas might be less abundant or in different places, but the systemic toxicity, how sick the patient gets, can be just as severe as gas gangrene. Myositis from aerobic bugs, viruses, parasites is rare.
Right. Let's switch gears to therapy. What's the overall approach?
It's a combination strategy. You need timely surgical debridement, removing dead tissue, appropriate antibiotics, good nutritional support for healing, and optimizing tissue oxygenation.
And sometimes hyperbaric oxygen.
Yes, hyperbaric oxygen, HBO2, in selected cases. Surgery itself can range from just incision and drainage to really extensive excisions, sometimes even amputation.
And antibiotics are critical.
Absolutely essential. But there's the challenge we mentioned. Getting culture results takes time, and you need to target the positive bugs, not just the ones hanging around.
So what do you start with?
Usually broad-spectrum antibiotics initially, covering the likely suspects aerobes and anaerobes. The chapter mentions combinations like penicillin G or clindamycin, plus metronidazole for anaerobes, and something like gentamicin or tobramycin for gram-negative aerobes, maybe a third-gen cephalosporin sometimes.
You mentioned clindamycin might be better than penicillin sometimes.
Yes, the chapter brings up the eagle effect and work by Stevens. It suggests penicillin might not work as well against strep when the bacteria aren't multiplying rapidly. Clindamycin might be more effective then.
Interesting.
Animal studies even showed clindamycin might give better survival even if treatment is delayed compared to penicillin in muscle infections.
Okay, and hyperbaric oxygen, when does that come in?
It's indicated when normal air isn't enough to get adequate oxygen to the infected tissues. You can actually monitor this, measuring oxygen levels through the skin or even directly in the tissue or muscle.
What's the thinking behind using HBO2? How does it help?
Mater and Tom's rationale is mentioned. Basically, breathing pure oxygen under pressure boosts tissue PO2, the oxygen level. This helps wound healing, helps those phagocytic immune cells work better. It might also reduce swelling, improve circulation, stimulate fibroblast growth and collagen formation, all good for host defense and repair. There's also Bell's algorithm mentioned for guiding its use.
But the evidence, is it clear-cut?
That's the tricky part. Evaluating clinical studies is hard because patients are so variable, infections are complex. Randomized controlled trials, the best kind of study, are really challenging to do for NSTIs.
So there's some debate.
Yes. Tibbles and Easelsberg are mentioned as critics, emphasizing the need for more prospective trials specifically for HBO2 and necrotizing fasciitis. A lot of the support comes from animal studies, case reports, retrospective looks back at cases, and just a few prospective studies.
But there is some positive evidence.
Oh yes. Korhonen's work showed HBO2 definitely raises arterial and local oxygen levels near the infection. And improved outcomes were reported in Fournier's disease when HBO2 was added to surgery and antibiotics. Some people even advocate using honey for wound healing in NF, the chapter notes.
Okay, let's focus on therapy for progressive bacterial gangrene specifically. Prognosis is generally better here.
Generally better than NF, yes. Often the outcome depends more on the patient's other underlying illnesses. Surgery is usually less aggressive, limited necrotomies, small excisions, maybe daily, standard wound care, temporary skin covers, skin grafts later. Big excisions are rare. Amputation is a last resort.
Any specific wound care mentioned?
A study by Heinle et al. Found better results after grafting using a 5% mafenate acetate solution, with a trend towards lower mortality and morbidity.
And antibiotics for PBG.
Again, the goal is to target the cause, which is tough with mixed cultures. An example is given where lots of bacteria were found, but the patient did fine with just local care, no specific systemic antibiotics needed for all of them.
But if you do use antibiotics,
Since strep is often found early, penicillin G is a common starting point, adjusted later based on how things go in culture results. Clindamycin use is increasing, maybe because strep can become less responsive to penicillin later on.
what about HBO2 for progressive bacterial gangrene?
Lettingham and Thorani reported benefits way back in '75. There's growing support in the literature. The way HBO2 works, boosting oxygen, helping immunity, makes sense for why it might help. The author shares their own positive experience using it when other treatments failed.
But no definitive trials.
No proper prospective randomized trials specifically for HBO2 and PBG, the chapter acknowledges. But based on experience, the author recommends considering adjunctive HBO2 when other treatments fail, especially in patients with serious underlying disease, systemic toxicity, or compromised immunity.
Is there a specific protocol?
Yes, a specific HBO2 treatment protocol is provided. The chapter also notes that the ideal oxygen dose or pressure isn't fully established. An oxygen challenge test, seeing how the wound oxygen level responds to HBO2, is considered important.
What about that anaerobic clostridial cellulitis, the more benign one?
Right. Usually Clostridia in pure culture, tissue necrosis, lots of gas, but no deep fascia or muscle initially.
Yeah.
Surgery is usually just incision drainage, excision of dead tissue. Penicillin G is the antibiotic.
HBO2.
Adjunctive HBO2, using the gas gangrene protocol, is recommended if the patient is immunocompromised or systemically toxic. A specific protocol is given, suggesting stopping HBO2 once normal tissue oxygen levels needed for healing are achieved just breathing normal air.
Okay, now therapy for necrotizing fasciitis. The cornerstone here is
Surgery. Aggressive surgical debridement. That's number one. Early, extensive incision into healthy tissue, removing all necrotic fascia and non-viable tissue. Often needs repeating. Patients might go back to the OR within 24 hours for another look.
and speed is key.
Absolutely essential. Don't delay surgery waiting for cultures. Delay increases mortality, plain and simple. A diverting colostomy is often done for NF involving the genitals or perianal area.
How do they know how much fascia to remove?
By exploring with a finger blunt dissection and just looking directly, viable skin flaps can often be saved. You know you're getting control when you don't see any more dead fascia. It might take 1 to 5 debridements, typically. Systematic exploration of the ischiorectal fossa is important in perianal cases.
Antibiotics for NMF. Important, but secondary.
Exactly. Important, but surgery comes first. Antibiotic choices change with new drugs and resistance patterns. Prior antibiotic use matters too, as it selects for certain bugs.
And the risk of treating the wrong bug.
Yes, the chapter cautions against targeting concomitant organisms, the bystanders, instead of the actual causative ones, especially with mixed cultures. Unnecessary antibiotics just confuse the picture more. Strep is often a major pathogen here.
So drug of choice.
Often penicillin G, with clindamycin as an alternative, especially thinking about that eagle effect. Metronidazole for anaerobes is usually added, and or maybe a third-gen cephalosporin for anaerobes and enterobacteriaceae. Clindamycin or metronidazole are needed for Bacteroides fragilis. Mater's initial antibiotic choice scheme gets a mention.
And HBO2 for necrotizing fasciitis. Still debated.
Still discussed. Clinical reports suggest it's a valuable adjunct, part of the overall management. But large, controlled, randomized trials are still lacking. A German medical journal discussion highlighted differing views. Mortality remains high, 20–75%.
The chapter summarizes a lot of studies on HBO2 for NF.
It does. Studies by Lettingham, Riedels-Nielsen, the author's own series, Mater, Reisman, Brown, Korhonen, many others. Mostly retrospective, sometimes with contradictory results, but many suggest benefits.
Like what kind of benefits?
Things like reduced mortality, needing fewer debridements, less tissue loss, maybe lower amputation rates, especially in the really sick patients.
But the Cochrane review wasn't definitive.
Right. The 2015 Cochrane review concluded there weren't enough high-quality trials to strongly support or refute HBO2 use. More research needed. Crucially, HBO2 must never delay surgery.
Other factors influencing HBO2 use.
The extent of infection body surface area involved predicts outcome. Large Fournier's gangrene might be an indication for HBO2. And for compromised hosts with NF who have high morbidity and mortality anyway, HBO2 is seen as a valuable tool. Again, a specific protocol for use after the first debridement is provided.
Okay, lastly, therapy for non-clostridial myonecrosis. How is synergistic necrotizing cellulitis treated?
Since its classification is tricky, maybe being advanced NF or myonecrosis, the therapy is basically the same as for NF. Mortality is very high here, often 75% without HBO2, because patients are usually severely immunocompromised. So adjunctive HBO2 seems logical.
Treatment protocol.
Adjunctive HBO2, usually the gas gangrene protocol, appropriate antibiotics, clindamycin, penicillin, and surgery, incision, drainage, excision of dead muscle. Prognosis gets worse if muscle is involved. For closed infections, like in drug addicts, early fasciotomy to release pressure and HBO2 are needed.
And that rare anaerobic streptococcal myositis necrosis.
Rare, but can be fulminant, really aggressive, mimicking gas gangrene. High mortality reported. Again, adjunctive HBO2 is recommended because of the proven tissue hypoxia. Gas gangrene protocol, often used in severe or compromised cases. Stevens' review suggested it might be more common than the author thought. High mortality seen in studies despite aggressive treatment. Animal models showed penicillin and HBO2 working better together.
Okay, so let's try to wrap this up, our deep dive into this chapter. It really paints a picture of NSTIs as, well, complex, dangerous infections needing fast diagnosis and combined aggressive treatment.
Absolutely. And understanding the history, the different causes, the changing bacteria, it's all crucial. Surgery and antibiotics are the mainstays, no question.
But this adjunctive hyperbaric oxygen, it shows promise.
It appears promising. Yeah. Particularly in sicker patients, certain infection types. But as the chapter acknowledges, we still need more high-quality research to really nail down its role definitively.
You were looking for a quick but thorough understanding, and hopefully this deep dive has given you that comprehensive overview, pulling together the key points from the chapter.
Yeah, hopefully in a way that's structured and makes sense.
For me, some aha moments were definitely tracing that historical understanding from Fournier and even earlier through Malini and Cullen, figuring out synergy, and then seeing the ongoing debate around HBO2. It shows how medical understanding evolves.
And we tried to structure it logically, balancing the big picture with the specifics, hopefully avoiding too much overwhelm on such a heavy topic.
So maybe a final thought for you, the listener, to chew on. Given just how serious NSTIs are, the high mortality, and the fact that evidence for some treatments is still being debated, where should future research and clinical practice focus most urgently to really improve outcomes for people facing these devastating infections?
A critical question. Thanks for joining us on this deep dive.